I'm going to ask Alex Abizaid to discuss the methodology and the status of the master randomized trial.
Thank you so much, Mari. Good evening. I thought that would be interesting to show you a case, perhaps to use as a rationale for the master study design. And I'll start with this patient that we treated a couple of weeks ago at Dante Pazzanesi. This was a patient that arrived with chest pain, ST elevation MI, 2 hours after the clinical onset. This is a lesion. This is a total occluded vessel, apparently with a lot of thrombus. So without any further discussion, we went ahead with a wire and crossed this lesion. As you can appreciate, some diffuse disease proximal, but massive anterior MI. We use an aspiration catheter, of course, after heparin, 2B3A, loading dose of clopidogrel. And this is the kind of image that you get after thrombus aspiration. We could open the vessel. The flow was relatively normal, but multiple passes of the catheter aspirating, you still see a lot of remaining thrombus and a lot of thrombus burden. I don't know how can you appreciate that. Perhaps here you can see better. So at this point, what can we do to minimize distal embolization? And first of all, a couple of questions. When and how often does it occur? How to avoid it? I think those are important questions. Promise 2-3 slides as a rationale. You see that it can happen as much as 20% in patients with acute MI. There is this interesting paper from Felix Zylstra that show that when we thromboaspirate or do conventional PCI, distal embolization can happen simply by doing angiography in 11 to 20% of the cases, during guide wire passage, balloon, and even during aspiration. But most of the time it happens when you stent. So I think that's perhaps the right time, and this is something that we can potentially avoid, since you cannot avoid doing angiography or crossing with the wire. So I think that's a good rationale for the use of a device like the M-Guard. So, and then I'm sure that everybody is very aware of some preliminary data that we can use as a rationale also to design the master trial, coming from Darius Dudek with 60 patients using the M-Guard stent for ST elevation MI. You see that most of the patients, 90%, got TIMI-3 flow. Myocardial blush, normal in O3, more than 70%, and a good number of patients, the great majority with ST resolution. So without any further ado, this is the design of the master trial. We included, and we are still including, patients with ST elevation MI within the first 12 hours of clinical onset with 2 millimeters of ST elevation in 2 contiguous leads. Patients screening for clinical inclusion-exclusion criteria and after signing the informed consent. Then we do angiography. We recognize that there is a lesion. When there is TIMI 0 or 1, we go ahead and we do what we generally do in our practice. We cross with the wire, aspirate. Some of you can argue that sometimes you don't need, but most of us, I think we're going to do thrombus aspiration and pre-dilatation. When you open the vessel and have TIMI 2 or 3, then is the right time to randomize the patients to either to M-Guard or to your regular practice of bare metal stent or DES. Primary endpoint will be measured by ECG at between 60 to 90 minutes. That's the ST resolution. And we're going to keep following this patient in multiple times, 30 days, 6 months, 12 months. And there will be a sub-study with angiography after 1 year, immediately after 1 year, 13 months, and an MRI sub-study between the 3rd and the 5th day. So I think that we're going to learn a lot with this trial. I have to recognize some of the leadership and people that worked hard to make this trial happen. Of course, the 2 chairmen, Greg and Mari. I co-PI with Darius and Sigmund. Those are the countries that are contributing with the master trial, and the number of sites per country, as you can appreciate, mostly in Brazil, Europe, and South Africa. Just perhaps to finish this talk and then come up with the solution for that particular patient that I started my presentation. This patient was randomized for the master trial. We went ahead with stent implantation, with the M-Guard implantation. This was randomized for the M-Guard. You see some diffuse disease, but the vessel is wide open with normal flow. This was immediately after stent implantation. That huge plaque burden disappeared, you can see beautifully. And for some of you that sometimes question us about side branch patency, I think this is a good example. Despite the big thrombus burden that was there, this was after M-Guard implantation with preserved side branch, this septal that is still open. Perhaps to better appreciate in a different view, you see that the vessel is open, and we have a very acceptable result. Thank you so much.
This study is going to provoke a lot of interest as we do the data analysis.